Okay, yeah, go ahead.
Okay. Welcome, everyone, and thank you for joining us today. We are Pre-Health Shadowing, an international nonprofit organization. Our mission is to empower aspiring healthcare professionals by providing virtual shadowing opportunities. We are thrilled to have you here as part of our community. Your participation and support is crucial in driving forward our shared goals in the medical field. As part of our commitment to inclusivity, we provide closed captions to support students of all abilities and needs. We value your feedback and are always looking to improve accessibility. If you have any ideas or suggestions, please email us at info@prehealthshadowing.com to ensure our communications don't get lost in your spam folder. Please save us as a contact. By joining our email list, you'll never miss a session update. We're on Instagram at Priel Shadowing. If you're on TikTok, you can find us there too with the same handle. Don't forget to sign up for our email list. It's the best way to ensure you're always informed about our latest sessions and opportunities. We are thrilled to welcome students from all around the globe. It's always fascinating to learn where everyone is joining. So feel free to share in the chat where you guys are calling from. I'm in California. Oh, nice, nice. Okay, can you move to the next slide, please? Oh, Virginia. Hi, Virginia. New York. Love that. Okay, so are you interested in becoming a part of pre-health shadowing? We have a fantastic opportunity for you to join us as a volunteer. It's completely remote, so you can contribute from anywhere in the world. To get started, just register on our website to gain valuable experience and make a positive impact in the pre-health field. If you have any questions, feel free to ask or visit our website for more information. We're recruiting for our leadership team, and it's open to everyone. This is your chance to apply your skills, learn new ones, and make a real impact, all from the comfort of your home as it's 100% remote. Just head to our website and fill out the application form. Let's take a closer look at the available leadership roles within pre-health shadowing. We are looking for leaders in all these departments. You could also propose your own department role here if you would like, if you feel it can holistically help PHS. If any of these roles resonate with you, I encourage you to use the link provided to join our team. These are the available leadership roles. Our high school training program, or HTP, is a fantastic way to gain valuable skills and insights in both leadership and the healthcare field before you step foot on a college campus. All you need to do is fill out the interest form available on our website. Our entire operation relies on the generous donations and invaluable time contributed by our dedicated volunteers. This is what allows us to continue offering these opportunities to learners from all backgrounds and walks of life. If you have the means, please consider making a donation. Every contribution, no matter the size, helps us maintain and grow this inclusive educational experience. Feel free to type any questions you have in the chat. We want to make this as interactive and as informative as possible, so don't hesitate to participate. After completing this session, you'll have the opportunity to earn a digital certificate. This certificate verifies your hours and can be accessed on our professionals course page at prehealthshadowing.com. It's important to take good notes during your shadowing experience. These notes will help you during the assessment, but also enhance your learning. Remember, the certificate is a great addition to your professional portfolio, showcasing your dedication and the skills you've acquired. If you guys could turn your camera on, that would be great too. This approach aims to replicate an in-person environment, enhancing the experience. Now I'm pleased to hand things over to our professional guest, Dr. Apurva Bhatt. We'd love for you to share a bit about yourself and take it from here.
Hi, everyone. I'm so excited to be here. It's very exciting, and I want to make sure I can share. I have a couple of slides because it helps keep me on track. Can you all see this? Excellent. All right, we're in business. So I'm a child and adolescent psychiatrist at Stanford, and I'm going to talk to you a little bit about what I do and hopefully be able to answer your questions about my journey and sort of the path to becoming a child psychiatrist. And I'll talk a little bit about the unicorn in a bit. Um, we have a whole plan for today, but I wanted to kind of do a quick, just kind of get a pulse check. How many of you are familiar, like can raise your hand or put your response in the chat? How many of you have met a child psychiatrist before or know someone who knows or know a psychiatrist essentially? Okay, we've got some folks. Uh, okay, so we've got some people. I'll be honest, when I was in my like my undergrad years, I had no idea what a child psychiatrist was. I had never heard of it. It was very new to me. So it's always helpful to kind of gauge where folks are at. So I'll talk a little bit about who I am, and then later on in the talk, I'll describe a little bit about what I do. But I think it's important to kind of describe what a child psychiatrist is for those of you who may not be super familiar. There's also a lot of misconceptions on social media, and I would say generally in the media about what we do. So I am a child of immigrant parents. I was born and raised in the Chicago suburbs. And I grew up in a multi-generational household. So my all four of my grandparents lived with us growing up, and my parents worked multiple jobs to help support us. I am one of three siblings, and at various times we had different family members living with us, aunts, uncles, cousins. So it was a really big household. So I've always grown up with a lot of people in my house. And I felt really fortunate to have a lot of family support growing up. I went to public school. I didn't know my parents are not in the medical field and they're not in academia. And I am the first physician in my family. I went to public school where not a lot of people actually go to college, and not very few even go on to do grad school or medical school. Back when I was in high school, I was mostly an athlete. I was not really like a straight A student. I had failed classes before. I had to drop down out of honors classes sometimes. And my guidance counselor knew that I had a strong interest in medicine. Since I was really young, for some reason, I had this thing in my head. I wanted to become a doctor. And part of it was like I liked helping people. And my parents, I'm of South Asian descent, my parents were actually ironically like kind of worried about that. They were like, that seems like a really tough thing. They were not pushing me into the field, in contrast to I think a lot of Indian families where maybe the kids feel that pressure. Um, so I was kind of navigating all of it on my own as a high school kid. I thought I was going to go to like a local community college or maybe even one of the state schools. And I actually got into like local Chicago state schools. And at that time, I remember when I was in my senior year of high school, my guidance counselor kept pushing me to apply for this 6-year program at the University of Missouri, Kansas City. And I didn't know what that was. And when I looked at the application requirements, and the people that went there, I was like, this doesn't sound like me at all. I don't think I'm good enough to get into this kind of program. And he said, he was like, you just need to trust me, like just apply to this program. You have a good chance. And back when I was applying, majority of the students that went to that program were like legacy admissions. So these were children of physicians who had graduated from that program. That was like a vast majority of the students that went there. My year was the first year they started doing holistic application review, where they took into account somewhat like not just the grades or the test scores or the lineage, but also just someone's genuine interest in becoming a doctor. And they started admitting more students that I guess had diverse backgrounds. So I was one of the kids with diverse background in that program. And so it is a 6-year program that is right out of high school. So after you graduate high school, that fall, you enter both undergrad and med school at the same time. Your first 2 years, you're doing a lot of undergrad prereq kind of work, finishing up your undergrad degree essentially in 2 years. And so you're taking a lot of credits. It's pretty intense. I don't think I knew what I was signing up for, honestly, when I joined. So I survived those first couple of years. And then later on in the years 4 through 6 is all medical school related stuff. And so when I got in, I remember being shocked, number one. I couldn't believe that I had gotten into it. And then my parents were like, it seems like a really good opportunity. You should do it. And so I ended up moving away and living in Kansas City for a long time to go through that program. And I'm really grateful to that program. It was really, really tough, I think, for me, but I think it helped me grow in ways that maybe I wouldn't have. And I also have gratitude for the ability to just get through medical school without having to take the MCAT. Now I realize how challenging that step can be and how stressful that is. And I didn't have to go through that. So I stayed in Kansas City for the 6-year program. When I was there, I actually extended by a year due to various things happening at home. I had a lot of family responsibility caring for my grandparents who at that time were aging and had a lot of health issues. And I had to go back and help care for them. And so I ended up extending an extra year. And then I went on to do my residency also in Kansas City in psychiatry. When I was in residency, I would say even back in medical school, I knew I was going to work with kids. I have always wanted to work with kids. I liked the younger populations. But when I did my pediatrics rotation, I hated it. I was like, oh my God, this is like making kids cry every day. They don't want to meet the pediatrician. They have no interest in any of the interventions that pediatricians do. And so I think my peds rotation was a little bit soul crushing because it was just so much crying. And also just kids are a little gross. I was a little bit germophobic and you'll get snotty kids who are just wiping their boogers everywhere. And I was like, that is not for me. But at that time, I got to see a child psychiatrist on that peds rotation for the first time who was caring for a girl who had overdosed on lithium. And I had witnessed that interaction and I was I had no idea what kind of doctor that was, first of all. I just remember standing on the outside of that room and watching that interaction and it being so positive. The girl seemed genuinely happy. It seemed like a positive interaction. They were at one point laughing. So I remember I asked that doctor, what kind of doctor are you? And they explained, I'm a child psychiatrist. And I was like, what is even that? How do I do that? That seemed great, what you all did. So then from there, I knew I was going to do child psychiatry. When I was in my adult psychiatry residency, which was in inner city Kansas City, we worked at a safety net hospital and then also the state inpatient forensic units, which are home to people who, in the state of their mental health episode, they accidentally did a crime of some sort. And it can range from really small crimes all the way to murder. And I had seen and worked with a lot of people who had pretty serious mental health problems, including psychosis. And I had always wondered, what would have happened had we intervened and supported those people when they were early on, even when they were kids, would they have ended up in that situation? And so when I was applying for child psychiatry fellowship, which I'll explain in the next couple slides, I knew I wanted to work with people experiencing psychosis, specifically kids and teenagers. And so, yeah, that's a little bit about me. I do a lot of different things at Stanford, and I have a whole slide dedicated to that. So I'll explain that. Some of my interests are working with adolescents. I really like the teenage populations. I like the little ones too, from time to time, but I think adolescents or, from middle school all the way to early college years, it's a really pivotal moment for a lot of people. People are developing who they are and figuring out their identity and, their values. And it's such a joy to work with teenagers. They prefer and really value genuineness. And if you are not genuine going in, you're going to get roasted in those interactions. So yeah, I really like working with teenagers. I work with a lot of athletes. I also work with a lot of individuals who are pretty high functioning students who experience a first episode of psychosis, who then are like going back into their trajectory of school and jobs and things like that. And in my free time, I like drawing and painting and also doing a lot of gardening. So that's a little bit about me. Um, I'm gonna just briefly, so child psychiatry is a medical subspecialty. So you have to go to medical school to become a child psychiatrist. And you are working with kids and families, and kids who are struggling with emotional or behavioral illnesses. And we work with individuals to evaluate, diagnose, and treat mental and medical illnesses. We do a lot of different things, right? We make a huge difference in kids' lives. The supports that we offer can change a child's trajectory forever in a very positive way. We also spend a lot of time with patients and kids. We use a lot of art and science, sort of combining those things to help treat things. And we work a lot with families to help family members and especially caregivers understand their child better. That's really critical. We take into account the whole person. So when we're assessing a kid or working with the family, I'm thinking about not just the kid's behavior or the symptoms, but like what is the lore of that child? Like what has happened to them? What's their family background, their religious background, social factors, environmental factors, the medical things that might be going on as well. Child psychiatrists do a lot of different things. We diagnose mental health conditions, but also sometimes medical things too. We may order labs or tests as part of what we do. We prescribe medication if needed. We do therapy. We collaborate with other medical teams, and we work sometimes in big interdisciplinary teams. So not just with other psychiatrists, but maybe with pediatricians, with psychologists, social workers, kind of the big team. I work in a big team, and I'll talk about that as well. And then sometimes people do interventional psychiatry. So that's like transmagnetic stimulation or neuromodulation. If you're in academia, you might do teaching, you might write, you might publish articles or write books. Sometimes we testify in court, and some of us do mental health advocacy. There's a lot of different subspecialties within child psychiatry. So I'm an academic psychiatrist. So I work within an academic institution named Stanford. I also do some research, but I'm not part of like a big research lab or anything like that. And I do work in systems of care, and I'll talk a little bit about EPI-CAL, which is some of the systems of care work I do. Some psychiatrists work in legal settings, so they might work with children who are involved in the foster care system. They might also work with adults who are incarcerated, who may have mental health struggles. Some do also infant work, so working with mom and baby to help promote bonding and healthy development. All right, what's the path to becoming one? I feel like I did not know this path, so I thought it might be helpful to share like what is the path to becoming a child psychiatrist. So you got to graduate high school. Usually that's 4 years. And then after that, most people will do 4 years of college to get your undergrad degree. And then they study for the MCAT, and then you get into medical school. Med school is 4 years. And from medical school, then you'll apply there's different paths actually. You can do adult psychiatry, which is what I did. And then you can fast track into child right after that. There's also triple board, which is another path. So it's pediatrics, child psychiatry, and adult psychiatry. That's a 5-year program. And these individuals are board certified in 3 different specialties. So child, adult, and pediatrics. There's also the PEDS portal, which is you become a pediatrician and then you choose to do a fellowship after that called PEDS portal. I think it's usually a year or 2. And then there's the combined residency, which is internal medicine, family medicine, and psychiatry. And then you would do another 2 years of fellowship after that. So it's a pretty long path, like more than a decade of my life I have spent in training. Child psychiatry fellowship is 2 years long. And the path that I took was my college and medical school were a total of 6 years. And then from adult psychiatry residency in my 3rd year, I fast tracked to child psychiatry. So I was able to save a little bit of time there. And then after child psychiatry fellowship, you can actually do even more fellowships. So there's forensics, there's consult liaison, where consult liaison folks work inside a hospital and are consultants to the medical teams. You could do addiction. There's even a new sports psychiatry fellowship. So there's a bunch of different ones you can do after that. Kind of zooming into what is psychiatry training. So the first couple of years here, these first 4 are your medical school kind of rotations. So you take the MCAT, and then after that, you're going to take, your step 1, step 2, do all of your medical rotations. After that, your psychiatry years, so adult psychiatry is these light blue ones. So we work in all different settings. We work on the outpatient side, in clinics. We do work inside the hospitals. We work inside emergency rooms. We start doing therapy with patients. So it's a very long path, kind of multiple different clinical experiences. And then child psychiatry is 2 years. And it's, again, a combination of working inside a hospital, working inside a clinic, working in schools, working in the community. Some of us work in forensic settings, so jails for kids. And yeah, that's kind of the whole path there. By the time we're done, it's like 24,000 hours, or I think it was like 20 or 24,000 hours of clinical experience, which is very different if you were to become like a non-psychiatry person. So like there's other paths to becoming a mental health provider, including nurse practitioners or PAs, which is a lot less number of hours of training. So just the trainings are different. Child psychiatrists can work in a lot of different places. We work in hospitals, sometimes medical hospitals or psych hospitals. We might do telehealth. You might work in the residential centers or schools, jails, clinics, and sometimes even working for sports teams. There's a lot of benefits. I love what I do. I love what I get to do on a daily basis, and especially the work that I do with some of the young people. I will say that, there's a lot of job opportunities after you graduate fellowship. You're in high demand even now, and I'll show you a slide in a second about the demand. There's really good work-life balance compared to other specialties of medicine where, like, if you're doing surgery, you're on the clock from like 5 a.m. to like 6 p.m. most days, and you are on the entire time. It's hard on the body. But some people like that, and that's good for them. For me, I really valued work-life balance. You also have a lot of flexibility. Like, you're not just tied to working in a hospital. You could do part-time, like, decide to work for a sport team and have your own small private practice and work for a county mental health system. Like, you could work in like 6 different places if you wanted. I will say there is also a lot of opportunities to do advocacy. A lot of child psychiatrists do advocacy work and policy work. So that's another whole thing. A lot of us have leadership roles because there's not a lot of people that have this much training in child mental health. So that's another big thing. Here's the map. And this is like, I think as of last year. So as you can see, most of the US is in red. Like, there's no child psychiatrist in that area. Orange means that there's a severe shortage, and then sufficient supply is the green. So we are considered unicorns in medicine. There's like very few of us out there being available to the community and able to serve the populations. And so there's a huge need. And the other challenge that's coming down is the average age of most child psychiatrists is 52. I think it's gone up a little bit actually in the last year, which is a huge problem. That means that in the next decade, a vast majority are going to retire, and we're going to have problems. There's not enough people to come in and help support. So there's a huge need. I can't emphasize that enough. If you're curious about child psychiatry, I encourage you to check out these resources. The American Academy of Child and Adolescent Psychiatry has a lot of great resources on their website. They have stuff for medical students. They have a great conference each year in October that if you were like, I just want to see what it's like, and if it's accessible to you, it's worth visiting in person to that conference. The APA is another great organization. It's going to be happening here in San Francisco in May. And that's actually how I met Ashley, is through one of their mentorship programs. So they have a lot of great like mentorship kind of opportunities for undergrads and like pre-health folks as well. And then there's these different social media accounts. All right, so I just talked to you about everything that child psychiatrists can do. Now I'll talk to you about what I do. So as I mentioned, I'm a child and adult psychiatrist at Stanford. I'm also a clinical assistant professor here. And I do a lot of different things here. The first thing that I do is I'm director of the Child INSPIRE Early Psychosis Clinic, which serves kids who have experienced psychosis. And I want to show a video about what I mean by that in the next slide or two. I also work in our adult early psychosis clinic called INSPIRE and INSPIRE360, which offers more intensive supports to people experiencing psychosis. I also work in several of our local school districts as a school psychiatrist, and I'm available to teachers, admin, school principals, if they have any clinical questions related to mental health. Sometimes it'll be really broad questions like, we're thinking about having this mental health event. What do you think? Or it could be like, hey, we're really worried about this student who had XYZ things happen. Are you able to kind of help support with a consultation? And then I also work for the state as part of our statewide Early Psychosis Center of Excellence, and I'll talk about that in a second. So I wanted to talk a little bit about psychosis. I'm going to switch the screen. Give me 1 second. Let me share the sound. Oh, actually, wait, this is not very well. Sorry, 1 second. There we go. All right, we're in business. Can you all see the live your possible? Okay, so actually, before I jump into this, how many of you have heard of psychosis? Like, raise a hands. Yeah, a bunch of you folks. Awesome. So psychosis is a constellation of experiences, and it's unique to each individual, but generally it is when someone starts to hear things or experience things that others don't. So like hearing sounds, noises, voices. They might have visual experiences that others don't experience, or feeling things inside their body, smelling things that others don't smell. And then sometimes there can also be unusual thought experiences where they start to have thoughts enter their mind that may not be true, or maybe a more intense kind of belief that is not shared by their family or their culture or their religion. And those combo of experiences start to really affect their ability to do day-to-day tasks, take care of themselves, function at a level that they're used to. Psychosis can be due to many things. It can be due to medical things like autoimmune conditions. It can be due to infections. It can be due to seizures or epilepsy. And then if all the medical things have been ruled out, then it could be due to mental health conditions like schizophrenia, bipolar disorder, or depression. And so I wanted to, a lot of the folks that I work with have schizophrenia spectrum stuff, but also a lot of medical psychosis as well. And I want to mention that like a lot of the stuff that's shown in the media is not accurate around psychosis or, the recovery potential of individuals living with psychosis. I think a lot of the movie portrayals and news articles always focus on like violence and stuff, and none of that. We know that studies consistently show a vast majority of people living with psychosis are not violent. In fact, they're more likely to be victims of violence than perpetrators. And so it's really important to me personally to like share like what's possible. And so there's this campaign, I'll put it in the chat if anyone's interested. I'm not sponsored by this company, by the way, but they do have great videos on what people can accomplish. And so I want to share one of them. Let me see if I can find it. Let's do Cecilia's today.
I've partnered with Bristol Myers Squibb on its Live Your Possible campaign to help empower people living with schizophrenia. My name is Cecilia McGow. I'm an astronomer and also the founder and executive director of the nonprofit Students with Psychosis, and I happen to have schizophrenia. At the age of 17, I co-discovered a pulsar and helped represent the United States in the International Space Olympics in Russia. And I was also a Virginia Aerospace Science and Technology Scholar at NASA Langley Research Center. So that was when I was like 17, 18. And I'm returning back to NASA I was first diagnosed with schizophrenia my sophomore year of college. I first experienced schizophrenia-like symptoms for as long as I can remember. Even as young as like 4 or 5, I would see shadowy figures or hallucinations coming out of my closet. It was really my junior and senior year of high school where my hallucinations became much more vivid, and it just snowballed into college. I was struggling with my mental health, and this was when I was in college. And I tried to do the responsible thing by going to the ER. And I stayed there overnight, and the doctor said that it was okay for me to return back to my dorm room. However, when I returned back to my dorm room, I was not only greeted by my 3 roommates, but also the RA and a can help person. I understand why they were concerned about me. I would have been concerned about me as well. And we all talked and decided that I was going to have another inpatient stay. But what happened next was really inexcusable. They brought police officers into my dorm room in full uniform. They patted me down in front of my roommates, and I had to convince them not to put handcuffs on me. They then escorted me into a marked police car that was parked outside of our dining commons, where friends were passing by and seeing me put into that police car. And I want to emphasize that I have in no way in my history any violence, and I was in no way refusing to go. It was just a mode of transportation to get that medical help. So when I came back to the university, the cat was out of the bag. People knew something was up, and I had to set the story straight. So that's when I opened up about my schizophrenia. I come from a troubled background. I lived in a homeless abuse shelter for part of high school. That's part of the reason why I focused so much on academics at a young age, because that was my ticket out of a very difficult situation. When I first got diagnosed with schizophrenia, I got a lot of pushback from my parents, not accepting of the diagnosis. And when I reached out to my mom, she would tell me that people would think that I'm crazy, people would think that I'm dangerous, and I wouldn't be able to get a job, and that would affect my sister's futures as well if this was on our family history. And my message to that is, don't let anyone, including yourself, get in the way of getting that proper medical treatment. Because I honestly don't believe I would be here today if I didn't get that proper support and treatment. I founded Students with Psychosis in 2018. We first started out as a club at Penn State, but because we got a lot of traction earlier on, ended up coming here to New York City to get the nonprofit off the ground. And what inspired me was by meeting fellow people with schizophrenia. In many ways, I acknowledge that my story is privileged. I didn't fall through the cracks at my university, and part of that was because I had a great support network from my academic advisor. A lot of students aren't as lucky as me, so I wanted to do something about it because I didn't want other students to feel as alone as I did or fall through the cracks. We want to make sure that students or advocates worldwide aren't afraid to say the words, I have schizophrenia. And we want to make sure that whether it's on the university or in general, that we're including schizophrenia, psychosis in mental health advocacy initiatives. Because right now, even in the mental health space, schizophrenia is shied away from because it makes people feel uncomfortable. We're very much focused on that peer support for the students. But I think the next big step for our students is helping connecting them with employment opportunities after university, because they're in college for a reason. And we want to take some of that support in helping empowering them there. Living your possible means to me living in a world where I'm not seen just for my diagnosis, that is just a part of me and it's not my full identity. don't let your diagnosis hold you back. I know for myself, I struggle with a lot of personal self-stigma. For me, living my possible is also at times getting out of my own way and challenging some of those preconceived notions of what a person with schizophrenia looks like or what a person with schizophrenia should do. For me, for example, thinking of the future, I would like to be a mom someday. For work, I'm returning back to astronomy and astrophysics this summer. So exploring back into the field that I very much fell in love with before I got my diagnosis with schizophrenia feels like a full circle moment. And living my possible in a career that is studying the stars and talking about human space exploration, for me, it's also leading by example for the students that I work with, that to shoot for the moon when it comes to your goals and your aspirations.
Any initial thoughts or reflections? Oh, Juan, thanks for putting this in the chat. In this video, this brought me back to when I was at university at the time when I did my criminology and policing degree. Yeah, police officers are not trained when it comes to mental health, especially in Canada and the US, and they don't have any form of formal training. So this is actually one of the most unfortunate things is, a lot of times when people are having a mental health episode, families don't know what to do. Sometimes they don't even realize it's a mental health thing. They just see as a behavior that's unusual or unconventional, and they may not understand why the person is doing what they're doing, and then police get called. In some cities, there are CIT officers or crisis trained officers that have received special training in mental health, but that's not the vast majority of police departments. So there needs to be much more work on that. Where I worked in Kansas City, we had a very strong collaboration with our police department. And as a psychiatry resident, I did the ride-alongs with the officers, along with a mental health social worker who, if we were getting a call that's a mental health related call, they wouldn't send the officer first, they would send the social worker and me. And so that I think went a lot better because there were many times I'm like, this person might have delirium. They looked like they had a medical thing going on. And I was like, we cannot, that they need to go to the hospital. And a lot of times they were usually quite ill and having other things. So it's important to have people that understand and can recognize a mental health or medical concern. Anyone feel comfortable coming off mute and sharing just initial thoughts or reflections? Yeah, go ahead, Daniel.
It was more just like a question for you, but do you think that maybe because of the fact that there's a lack of psychiatrists in the world, maybe that's why they send cops and not medical professionals?
Yeah. They save us for the hospitals because the hospitals own us. No, actually, part of it is, you're right, just the staffing, and we don't have enough child psychiatrists to be able to respond to every crisis call, unfortunately. Part of it is also law enforcement's duty, right, to serve and protect and keep communities safe. And so that's kind of literally their job. I actually think what would be most effective is if law enforcement was trained in mental health. I think they would do a much better job of responding to these things and also recognizing the kind of traumas that they are exposed to, police officers, fire department, folks, all these people are putting themselves in pretty high risk situations sometimes. And that can cause them to develop PTSD kind of symptoms that then cause their body to have a fast fight or flight response. And so then that can get activated when they see somebody having a mental health episode. Police officers, I think departments across the USA are doing a much better job of trying to encourage officers to get treatment. But it requires a culture change, and that can take time.
Yeah.
Go ahead, Mania? Sorry, if I'm
No, you almost had it. It was good. It's Manaya.
Manaya.
As a pre-med student, you would be pretty surprised if you went to my university, like the amount of students who are in this field who aren't well educated on mental health and not just really how to treat it, but also just the common misconceptions that are put on media. I'm very happy to say that I'm taking a lot of psychology classes to better understand it, but it's kind of concerning that not a lot of people know the common misconceptions of mental health and what's exaggerated in media and what can be resolved, and also the treatments that come with them with mental health. As somebody that, like, you can get treated for it medically, biologically speaking, or you could get psychotherapy for it, but it's kind of stigmatized even in media, which causes a lot of misconceptions. So I'm happy that the video informed, them about it, especially in like a university contents, because it's really surprising the amount of people who want to go into healthcare who don't really know how to deal with mental health.
Absolutely. And like you touched on a few things that I think stand out to me. One is like media portrayals are terrible. A lot of the movies, TV shows that show psychosis, really, I haven't really seen honestly like accurate portrayals, sadly. I know that there's a lot of people on social media now sharing their story, like people with lived experience of schizophrenia who are like very bravely, honestly, sharing their experiences and re-educating the public. I have a really lame social media account. I'm trying to get better. I don't have time to like dedicate as much to it. I'm trying to put more helpful content out there, but like, I think more psychiatry people or even mental health professionals need to be active on these platforms. Unfortunately, there's not that many that are doing it, I think, in a good way. A lot of them also like the folks that are on there also sometimes are like sellouts to these big like pharma companies or nutraceutical stuff. And so it's hard to find good information. And I also want to acknowledge there's a comment in here. I think the stigma, especially surrounding things like psychosis or depression, that's something that needs to be educated on. This is a huge problem. Um, Even in my own training, I think stigma is a huge problem. I think it's a problem within psychiatry, as Cecilia mentioned. A lot of psychiatrists get really stressed out or they avoid, working with people living with psychosis. And they kind of assume that there's like no good recovery potential, which is just not true. And I actually wrote about this. Can you all see this? So one thing I want to emphasize is that, like how we treat psychosis today is very different than it was like 50 years ago. We have newer medications, many people, a vast majority of people who have had psychosis go back to living pretty normal lives after that first episode. If they were able to access treatments that one worked for them and they were able to figure out the right combination of things. So it's not going to be just medication. It's not going to be just diet, exercise, therapy. There's a lot of things that they're doing to make sure that they stay well. We have this event every year in our clinic called the celebration event, and we celebrate people's milestone achievements. And I work with a lot of kids who have schizophrenia or bipolar disorder with psychotic features. And if you read the research literature, you'll always see that like prognosis is very poor if a child or someone under the age of 18 has had that kind of episode. And I clinically just don't see that. Like a majority of my kids do really well. They got their driver's license. Many are working. Some of my kids have got like perfect scores on the SAT. Like they're doing things that even like I'm not capable of. So, I think it's important to not assume how far or how high someone's going to go while living alongside this mental health condition. And just making sure that like if you do encounter somebody that you don't just automatically assume that their life is done or that they're not going to be able to pursue their goals or their dreams, because they will. So the other part of my job is I work as part of a big multidisciplinary team on the INSPIRE360 early psychosis team. And what this program does, it's a high intensity program designed to support individuals living with psychosis who are early on in their course. So usually within the first couple of years of their first episode. I serve as the psychiatrist, but then we also have an occupational therapist who helps folks get back to their functional goals and, kind of get back to like being able to do what they want to be able to do. She can also help with like sensory things, making sure the environment is setting themselves up for success. We have case management, family partners. This is somebody who works with the caregivers or family members to help promote their understanding and support of the person. We have a peer support specialist who's amazing, who has lived experience of psychosis and can help navigate a lot of different things with that young person and their family. We also have a supported education and employment specialist who helps people get jobs, go back to school. And then we have a therapist as well who can do group therapy and individual therapy. And so this is a highly coordinated clinic. We meet every week. We discuss every single person on our load in the program and try to make sure that each individual has what they need to succeed or make progress towards their goals. And then if things are coming up where like maybe someone's not doing well, we have a high degree of coordination to help support them so that they're not ending up back in the hospital or in the emergency room. The other part of my job is I work for the state of California through EPI-CAL, which is Early Psychosis Intervention California. And we are an organization combined, it's Stanford, UC Davis, and UCSF, where we provide training and technical assistance to every single early psychosis program in the state that's run by county programs. And our goal is to help improve the quality of care that's provided to individuals living with psychosis and their families. Right now, well, I guess before this year, counties could just do kind of whatever they wanted, and there was no requirement to provide like high quality care. So we're moving into a model that will now be checking how these programs are doing and making sure that they are truly serving the community. All right. I forgot to mention my schools work. I told you I work in schools. I am a school psychiatrist. I supervise child psychiatry fellows on their school rotation, where they are on site each week. And then sometimes they're seeing students, sometimes they're getting consulted for specific questions. And then I also support the districts in sort of training teachers and staff to help identify different mental health things or help them with navigating challenging situations. I think that's all the stuff that I do. All right, we're going to go into Q&A now. I hope that's okay. I guess I know there's questions in the chat. I don't know if somebody wants to start or if I'm supposed to follow a specific format.
Hi, Dr. Bhatt. I'm gonna ask the Q&As. I'm gonna read them off and then I'll read them to you and then you can answer the questions.
Perfect. Okay. And I'm going to stop
Okay.
sharing my thing here. Okay.
Give me one quick second. Okay, so the first question is from Julie G. She says, I see you hold multiple work roles, and I'm curious if you consider that to be one of the unique benefits of specializing in psychiatry.
Yeah, absolutely. Like, I think the fact that I'm able to work in a school, I'm able to work for the state, I'm able to work in a clinic and part-time, sometimes I'm in the hospital, is pretty unique to psychiatry. Most other specialties, you are either in a hospital or in a clinic, and you don't get to really work in other settings easily, or it's really hard to find those opportunities. So yeah, part of it is like specific to psychiatry, I would say.
Okay, thank you. The next question is from Jennifer L. Is psychosis just related to schizophrenia, or are there other disorders?
Oh, sorry, can you say that again?
This one is from Jennifer L. And is psychosis just related to schizophrenia, or are there other disorders?
Oh yeah, it can be, so psychosis can happen to many different things. So like I mentioned, it can happen to medical things like lupus, which is a medical autoimmune condition. That's actually what Selena Gomez has, and it can cause symptoms of bipolar disorder and psychosis. There's also, other kind of things that can cause psychosis, cannabis is a big one. There's a new study that showed that teenagers who were using cannabis heavily had a 52% increased risk of developing schizophrenia later. So it could be substance induced. There's also bipolar disorder that can have psychosis symptoms linked with those mood episodes. So that's another one. And then depression and postpartum periods as well. So after someone has given birth, that's a high risk period for developing psychosis. And then major depressive disorder is a big one as well. I actually work with a lot of kids who have had like autoimmune things going on. And part of it is because my clinic tests for these things. Right now, there are no good consensus guidelines on what medical testing we should be doing for people presenting with that initial episode of psychosis. So I'm in the process of actually studying the protocol that we developed in our clinic to see if the test that we run makes sense or if we need to be adding other ones instead. But I catch a lot of medical stuff in my kids who would have otherwise honestly walked away with a diagnosis of schizophrenia inappropriately.
Thank you, Dr. Bhatt. The next two are from Julie G. So the first one is, what is your experience of burnout and what do you do to manage it?
Yeah. When's the first time I had burnout? I want to say, so my experience of burnout varies. It depends on my load. Like when I was in school, I don't think I really felt burned out in high school. But I also I went to a public high school that I don't think they were dialing up the heat on us that much. And also I was in sports and I had a lot of other protective activities where I could let off steam. So even if I was stressed, the endorphins of playing high intensity sports really mitigates, I think, the emotional stress of school. And also playing sports has a lot of pro-cognitive benefits, like helping improve focus and things like that. So I didn't really experience burnout until I joined the 6-year program. And part of being in that program is, you are completing 2 degrees in 6 years that would traditionally take people at least 8 years. And so you get very little breaks when you're in that program. And so I didn't get to go home that much. And my parents couldn't really come and visit me that much because they had family responsibilities, including taking care of my grandparents. And I remember within that program, I started to kind of lose my passion for medicine. I wasn't sure if I was cut out to become a doctor. In the program, I frequently received subliminally the message that I didn't belong, sadly. And then there were also people that really did believe in me too, but I felt, sometimes when you're on rotations and you are treated differently for XYZ reasons, it was challenging. And I think for me personally, I was young, so I didn't have the confidence, of 1,000 suns that I have now. I was still very much I was a much different version of myself, I think, first of all, where I couldn't really stand up for myself. There are a lot of power differentials and dynamics. And so I remember back then feeling really burned out, just not having passion to study, not having passion to do the things that I needed to do on a day-to-day. And then I started, my grades started to slip a little bit when I was in the program. And so I was struggling then. And I noticed for me, it was I'm just not feeling that drive or that motivation to get up and do what I want to do. And so what I learned is that I have to take breaks personally, and making sure that I schedule time to do things that I genuinely enjoy, that are not related to medicine. So for me, it's going out in nature, going on hikes with my dog, being, exercising is a big one for me. I have learned my brain needs some level of physical activity or it is not going to work on peak performance. And part of that is I've played sports my whole life. So I think part of it is my brain is used to a certain level of endorphin hit from physical activity. So that's kind of how I learned to mitigate it, is introducing, making sure I'm scheduling breaks, scheduling exercise, scheduling kind of those things. The other thing that contributed to burnout for me when I was in medical school is, so I had a lot of financial and food insecurity when I was in the 6-year program. And back then they didn't really have programs to support medical students who couldn't afford healthy meals and things. And so I was living off of noodles, which is not healthy. I found out later after being diagnosed with iron deficiency, and they were like your diet is trash, and you need to eat healthier, and you need to eat more vegetables. And I was like, well, I can't afford it, so I ended up taking a second part-time job actually to help kind of supplement myself. But yeah, I think there's a lot of things that contributed to it. There's a lot of systems factors that were out of my control that led to burnout. And now looking back, I'm like, I should have, asked for help on all these different things. There were a lot of reasons why I didn't ask for help at certain moments. Part of it is like being the oldest daughter of immigrant parents. You are holding a lot of responsibility. There's a sense of like pride and wanting to always do things independently, and I have a much harder time asking for help. I now recognize that and have worked on that, but back then I didn't recognize those dynamics happening inside me. Um, so even now, like in my clinical work, like there are moments where things are tough. When some of my patients are really struggling, I genuinely am invested in them, and like I really care about them. And also I recognize like they're on their own journey. I'm here to walk alongside them. I'm not going to, control what happens to them. And sometimes it's hard when they make choices that like are ones that I don't agree with, or ones that I think are leading them to harm. And so the way that I deal with that is I just focus on the things that I can control and try to do my best to really be there for them in a very non-judgmental, humble way. And just being there for the ride. I'm not there to, again, like force them into anything. I'm just there to help support them. So that's kind of helped me with my burnout. I genuinely love what I do. I will say it's an honor and a privilege, to be a physician. I think it's an honor and privilege to work with people experiencing psychosis, and to bear witness all of the amazing things that they'll go on to do after, their episode has ended, and when they're back on working towards their goals. That there is such joy in seeing the things that they accomplish. That was a long-winded answer. Sorry.
No, it's okay. It was really insightful, and I'm sure everyone got a lot of information from that. So the next question, it's by Julie G. Do you lean more towards medication management, talk therapy, or an integrated approach with most patients?
I do both. All of my visits are 60 minutes. I don't do short visits. It's just when you're working with people who have experienced psychosis, one is they've spent a lot of time in systems of care where they haven't felt heard. So you think about ERs, you think about other kind of settings, like people are rushing, and I intentionally don't do that. I will like die on that hill in my career. I know the hospital frequently wants me to cut down my visit times. I'm not going to do it. And part of it is like, even if they're doing well, I want to make sure I'm there for them, like, and that I'm getting all the updates and understanding what's important to them, helping them work through family dynamics or friendship dynamics or relationship things, or navigating like, hey, they're applying for their first job and they're trying to think of how to disclose like to HR that they live with a mental health condition that they might need work accommodations for. And that stuff takes time. You can't rush that in 20 minutes. So, I make sure the meds are right and we handle the health part of taking medication. But then I also do a lot of other work. My goal is for each of the young people that I have the privilege of working with is to see them at like reach their max potential, whatever it is that they're working towards. And so you have to spend time. So I do both. I also do a lot of family work. And that's the other part is even if the young person is like, they're like, hey, I'm good. Sometimes you'll have like a very anxious parent, and just making sure that they feel like I want to make sure that they understand what's going on. That's very important. If the caregivers of my kid don't understand, it's going to lead to a lot of negative outcomes. And so I want to make sure both parents or whoever's involved understands what's going on, understands how to best support their kid. Here in the Bay, a lot of the kids feel a lot of like peer pressure to like, achieve a lot at a young age. And that's not healthy. It's not normal, like what's happening here in the Bay Area. So I try to like help parents understand that and not apply that same pressure to their kids.
Thank you. The next question is by, I'm so sorry if I pronounce it wrong, Samruthi. What is an example of a lab a child and adolescent psychiatrist would order. Also, you mentioned how art and science is combined to help people. Can you elaborate on how this is done?
Yeah, we order. So, like when kids come in for mental health evaluations, mental health conditions are like a diagnosis of exclusion, meaning you have to rule out all of the medical things before you label that as a mental health condition. So, for kids, it depends on what mental health condition you're thinking about. But like for depression, for example, I want to make sure that this kid is not iron deficient. I want to make sure that their vitamin D is normal. They don't have anemia, like they don't have autoimmune things going on. So there's n number of things that medical things that could be going on. And so I ordered tests to make sure we're not missing something. And then on the psychosis side, I like have $1 million workup that I do for these kids. They get MRIs and like EEGs to rule out seizures. We do a lot of autoimmune and infectious testing. And then ruling out like here in California, there's like a lot of like old metal pipes that have lead. And if you live in a rural community, you might be exposed to like arsenic. So there's a lot of like heavy metal thing and like environmental exposures that I test for personally. So I do a lot of like medical things to check to make sure we're not catching something that, or to catch and make sure that it's not a medical cause for the child's presentation. And then art and science, how it helps people. A lot of therapy in kids combines art. And part of it is like, for example, in the young kids, we do play therapy. It's not even really much talk. You're just playing with the kid and you're introducing therapeutic concepts through play, and you are observing their play to help understand what happened to that child. A lot of kids won't be able to verbally tell you what happened, whether it's something traumatizing or whether there's something that they're worried about or thinking about. It will come out in how they play with toys, and what toys they choose to play with and how they play with it. We do a lot of art-based work in our clinic. So kids will bring in, I think it helps to emotionally process stuff. So they'll do ceramics or paintings or drawings or write poems about their experiences. A lot of kids find that quite therapeutic. So that's kind of how it's sort of incorporated. But there's a lot of different ways like people do that. I have one kid who makes short films. It's great. She's like very gifted. I can't wait till she like makes it to the red carpet. But yeah.
Thank you, Dr. Bhatt. Michael, you have your hand up.
Yes, hello. Thank you for presenting. Since you mentioned about children having MRIs, I'm wondering myself is because I just got into a rad tech school, and one of the modalities that we're allowed to try is X-ray and MRIs. And I'm wondering, as a psychiatrist, if there's any mental aspect that us rad techs or imaging techs should worry as we're about to as we are about to give these imaging techniques, because we can know that like an MRI, it could be very claustrophobic.
Yeah. I don't know how many you've had MRIs done. It's extremely claustrophobic. Like it's a very, yeah, I'm like shocked that we don't have better technology that makes it a little bit easier. I will say that I think one is like just genuinely listening to the young, the patient if they're coming in and sharing that they're stressed about this, like really listening to them and reassuring them as best you can, giving them the tools that you can. I know like for MRIs, they'll give like the earplugs and like the headphones and like, make them comfortable sometimes with the blankets, warm blankets, things. So like anything you can do to just make that person feel human and feel heard, it can go a really long way. I like to show my kids like videos of the MRI sounds, and then I'll play it because it is part of like that one famous song. I forget the name of it. But like so that they're not shocked by the sound of the MRI. It's not a surprise. They've already heard it before. So that can help in like previewing the experience to them. And then for some young people, I actually ask them to do guided imagery. So like we'll practice like imagine yourself on the beach and like you're just hearing this weird MRI sound, but you are at the ocean, and like just like really trying to visualize that you are there and not inside this weird tube machine thing that is taking scans of your brain. And then also making sure you're working with the parents too. A lot of parents or caregivers know their child really well. They know most people don't go to these things alone. So if they have like a friend or a family member, just like if the family member has helpful information to share to make it comfortable, that could be helpful. But thanks for all that you do. It's important. Imaging. I've had good experiences with people doing images for me, and I've had negative experiences too. So as long as you're genuine and you care, I think it'll show through.
That's thankful advice. Thank you.
Thank you, Michael. Thank you, Dr. Bat, for answering his question. The next question is by Lila, or Layla, I'm sorry if I pronounced it wrong. If someone is interested into going more into the academic research and or advocate route, what would you suggest they look into?
Yeah. Academic research, if you are an undergrad or in like, those years, I think doing like research coordinator roles could be really helpful, and you can gain really meaningful exposure to different like big time researchers that are doing different things. So that's one option. And then in terms of advocacy, there are a lot of like youth like advocacy roles. Like I know Jed Foundation, like first of all, you should be on LinkedIn. You'll learn a lot about like and follow people who share these resources. But I know Jed Foundation has like different like advocacy roles. I think they have a program actually that they are starting this year. There's different nonprofits that have like youth advocacy roles that are paid like part-time internships or part-time jobs. You could even work with legislators on policy review. So like there's like admin roles or policy research roles that can be tied with different legislators that are creating laws related to mental health, and your job would be to help them with different things. I'm trying to think of what else there is. And if you're somebody with lived experience of mental health, I know that even at Stanford, like we have different youth advisory councils, youth advisory boards. So those are really meaningful experiences too. Like you could just like Google in your area to see if there are any mental health organizations or nonprofits that have youth advisory boards. Even some legislators have youth advisory boards. So kind of like looking for those leadership opportunities, I think could be really great.
Thank you. The next question is, what do you think is the most challenging and rewarding parts of your job? What qualities do you think make a good child psychiatrist? And this question is by Netra.
Yeah. So I'll start with the most challenging. I think, so part of my role as a psychiatrist is ensuring that the young people that I work with are safe. And sometimes they're in situations that are not safe, whether they're being hurt by other people, being bullied, or being abused, and having to like report that and disclose that or do something to make sure that that person will be safe. That never feels good, like in terms of yeah, like sometimes there's retaliation that happens against my kid, and that can be really stressful. There's also the other side where sometimes my patients are maybe sometimes not doing well and they're a danger to themselves, so they're having suicidal thoughts or self-harm thoughts that are like now becoming more intense, or they might have thoughts to hurt other people, which is more rare. But it does happen, and when that happens, I do have to make sure I have to take steps to make sure they'll be safe, that they won't, accidentally do something to hurt themselves or someone else. And sometimes those things, if the person is not willing to collaborate, I sometimes am forced to like take more involuntary actions, like putting them on mental health holds. And I think that's like the worst part of my job. I hate doing those. I wish everything could be collaborative. And I also acknowledge that sometimes someone's mental health condition makes it hard for them to make safe choices. And it is my job to like be that safety net when they're falling, to make sure that we're catching them, so that they can survive that episode. When I used to work on an inpatient unit during fellowship and also during my training years. And I think for me personally, I'm not, I like inpatient, but I'm not cut out for it, because there's a lot of kind of scary things that can happen on inpatient units. it could be traumatizing environments for some people. And personally, that was not for me. So I don't work on inpatient units, but there were some challenging things that happened when I was on those units. The most, I will say another challenging piece of my job is, so a lot of the young people I work with have fully accepted their mental health diagnosis. Like they are terrified. They never want to have another episode again. And so they were like, I will take the medication. I'll do my therapy. Like I'm going to do the work to make sure I stay well. And I work with a lot of children of immigrant parents, like parents who are working in tech, who have immigrated from a different company or from a different country, who are working at some of these local tech companies. And they have different views of mental health than their child does who's growing up in the US. And so sometimes there's this gap between what the parents believe and what the kid believes. And, it takes parents kind of a long time to accept that their child might have psychosis or schizophrenia or bipolar disorder. And sometimes, and not infrequently, this happens quite a lot, where like the kid will be doing really well after that first episode. And the kid will be like, okay, now I'm going back into my honors classes. I'm going back into sports or music or art or whatever, that they do. And then the parents will ask, and inevitably will ask, when can we stop the medication? And the kid will like look at the parents and be like, what are you talking about? Like, I'm not going to stop my meds. Like, I don't want to have another episode. And the parents will sort of really want to stop the meds. And so then there's this like conflict. And so having to manage that conflict is really challenging because parents come with their own life experiences, their own background that influences how they view mental health. And some of that is like shaped by culture. Some of that is shaped by religion or spirituality. Some of it is shaped by their own personal experience of seeing another family member go through the exact same condition that their child is living with. And so it could be like that parent's own trauma reaction or avoidance of accepting like, oh my God, you're going to end up like this uncle who lives in this other country who never got help. And who's doing really poorly. And so having to navigate that conflict is really challenging. I have to like always stop myself I always stop myself to check in with how I'm feeling, if I'm feeling anxious or stressed. And then I react, like, respond to the parents and the situation. And a lot of times I just ask the child, like, what have you found helpful within your treatment and what's not helpful? And most of the time, like that will be the parent's answer. Like, I don't even have to say it, like their kid will say it for me. So that's very challenging, is like navigating cultural or religious kind of topics that maybe don't align with the Western model of medicine, and like having to try to make safe choices together with that young person and their parents. Rewarding parts of the job. I will say the best part of the job is like, I feel like I spend a lot of time in the rewarding part. The people's episodes are short-lived most of the time. And they are figuring out, what it takes to stay well. Because I work with a lot of young people, luckily they're surrounded by big safety nets. Like they have family, friends, like school, clubs, activities that they're a part of, sports. And so it's really rewarding to see the kids achieve things that you never thought that they could. Like, I keep an open mind. I really don't assume anything for any of my young people, but some of them like go really far. And like, like the kid who got like perfect score in the SAT, kids who are taking multiple AP classes, my college kids who are in really hard majors and just like crushing it. They're doing so well, despite taking like heavy-handed meds that make you very cognitively slowed, tired, like having to navigate, sometimes hiding your illness from your peers, or your, like, if you're part of a research lab, like not sharing that you have this thing. So they're navigating so much and they do it with grace. And like, that's the best part, is seeing them kind of achieve what they set out to do, or achieve their goals. And then what qualities do I think make a good child psychiatrist? I think one is you have to be warm and you have to like people. You can't really be a psychiatrist if you don't like people. I think also being humble is really important. Like not assuming anything about anybody is really critical. Being curious. And then being able to hold emotion. Distress tolerance is something that you grow in your training. I didn't come in with the ability to tolerate a lot of emotional stuff. When I first started, there were stuff that was really hard to listen to. Sometimes you're working with people that have been through awful experiences. And that's like back to back to back. And over time, as you know, over the course of your career, that tolerance to be able to hold that much like baggage or heavy material gets better. Like it's almost like when you play sports, right? The more reps you do, the stronger that muscle will be. And you're able to be objective and not let that like totally crush you at the end of the day. And so I think, yeah, just being able to kind of someone who's on that journey, I think, of growth will make a great child psychiatrist. You have to be willing also to look at yourself. The nature of training is that, especially when you're doing therapy, you know, sometimes certain situations or people will trigger emotional reactions inside you. And it is important to be very much aware of that because you never want to have an emotion or a response to somebody that could be harmful. And so it's like part of being a psychiatrist is you take a magnifying glass to yourself and your own life experiences. And it's a beautiful journey to be on because you're learning so much about yourself through the process of helping patients. I think no other field of medicine does that. You're never required to look at yourself. There's always this separation between you and the patient. So yeah.
Thank you. Oh, I'm
Yeah.
sorry.
Oh no, go ahead.
The next one is, what is the youngest age that a child can present symptoms of a psychological disorder? By M. Roland.
That's a great question. So children with developmental delays, like related to autism, can present really young, usually within the first like 12 to 18 months of life. You know, we will recognize if a child is behind in their milestones, like motor milestones, like walking, talking, sitting, crawling. There are some children who have medical conditions that are known to cause certain mental health problems. So like cognitive delays or intellectual disabilities or autism or, you know, ADHD. So it can start pretty young. We don't see psychosis that young though, that commonly. It's very rare. Usually there's something medical going on if a little kid comes to me with hallucinations and things.
That's really interesting, actually. Juan B asked, what development factors do you see in youth and adults with early psychosis that imply they will develop schizophrenia?
What, sorry, what are the developmental factors that I see?
Yeah, what developmental factors do you see in youth and adults with early psychosis that imply that they will develop schizophrenia?
So one is there's like no surefire guarantee that anyone is going to develop it. There are risk factors, I think, that can elevate one's risk into developing it. The first one being like genetic risk. Like if you have a first degree family member living with schizophrenia, you know, there are elevated risks associated with that. If you have a sibling living with it, you have a higher risk. Cannabis use is a big one. Like I said, teenagers who use regularly and heavily who develop a cannabis use disorder where their body is like sort of like kind of dependent on it, 52% increased risk. There's some prenatal factors like when mom is pregnant with the baby, if mom has certain risky behaviors like doing drugs or things like that, that can raise that child's risk of developing it, schizophrenia later in life. Also some specific types of infections in utero. So when mom is pregnant and if she has certain types of infections that can elevate the risk as well. But there's no like surefire, there's no guarantee that anyone will develop anything. It's sort of layers of risk that sometimes lead to somebody having it later in life. Trauma is another big one, exposure to trauma, so abuse, neglect, those kinds of things.
Oh my gosh, I'm so sorry. I was talking and I was muted. We're gonna do our last question. It is, do you think you would have preferred the regular 8+ year MD track over the 6-year program? By Netra.
That's a great question. I've thought about this a lot, actually. Unfortunately, that was never an option for me because I was locked in the 6-year program. I'll share two things. One is like, because I'm the first physician in my family and I'm the first person to go through that 6-year program, I don't think I knew what I was getting into. Like, I was blissfully ignorant entering the program. I had no idea like what I was signing up for. And I was just really grateful, and I'm still grateful that I got into that program. Did I know the level of sacrifice that would be needed, meaning sacrifice away from my family, not being able to support my parents during pretty stressful time in everyone's in their lives, with my grandparents' health and things. Um, that's something that I like looking back. I'm never going to get that time back. You know, I'm never going to get that extra time with my grandparents who then passed away when I was in the program. So I think there's a part of me that like wishes that that wasn't the case, that I had that time with my grandparents who like pretty much raised us, me and my siblings. So there's a part of me that I think like will always have a little bit of like sadness. I also think that now hearing about how challenging it is with the MCAT and like getting into medical school, I that part scares me, honestly. I know that that's very stressful, and having to like do all these things to be good enough to get into medical school. I think I'm grateful that I got into the 6-year one, and I never had to think about like the 8-year program. But um, I also think that the 8-year program, you get your summers, you know, you get time off, and I think that's something that like personally I value a lot. And had I known that the 6-year program would take that away, I may not have chosen to do it. But I didn't know at that time what I was signing up for necessarily.
Thank you.
Yeah.
Okay, actually, we do have a couple more minutes. We have until 5:25 to ask more questions. So the next one would be, what are the biggest opportunities in psychiatry that you see in the next 10 to 20 years?
Yeah. Oh man. So I'll share a few things. And then also I'll share like I'm always looking to improve, you know, these kinds of things. So if you guys have any feedback, feel free to fill out that form. So there's a lot of opportunities. So one is, you know, there's a lot more mental health awareness and like stigma reduction. And so I think there are more people seeking help than the number of providers available to adequately meet that need. We need more diverse people in this field. Like we can't have the same kind of person still in this field. Like it needs to be people of all different backgrounds, all different life experiences. I think there's a real opportunity to serve communities that have historically sort of been marginalized. Like personally, I'm very passionate about serving my own community within the South Asian community. I work with a lot of South Asian youth, so kids of South Asian descent whose parents, you know, are immigrants, and I feel like it's something that really draws me to the work. And so, you know, there's a real opportunity to give back to your community. There's also a lot of opportunity to like do things beyond the traditional like doctor role. So like, for example, you could consult with athletics teams or, you know, music schools or art schools. I mean, there's like n number of things that you could do as a psychiatrist. There's also the whole AI thing. I think AI is still not caught up to what we do, I think, but it might, I don't know, who knows. I will not speak I will not speak prematurely, I guess. But a lot of people prefer human interactions over chatbots. Like a lot of the research is showing that so far. So the tech hasn't caught up yet, but maybe there's an opportunity to create, you know, work in the AI space and help iterate safe models that can deliver mental health at scale. Yeah, so there's a lot of opportunities, I think, a lot of exciting things. And also I showed you that graph of like in the next 10 years, everybody's going to graduate. I mean, not graduate, they're going to, well, I guess it is graduating. They're going to retire. And there's going to be a huge need. We're already in a huge need situation. So it's about to get very much amplified in the next 10 years.
That's exciting because we could become the psychiatrist. Okay, now this is the very last question. Thinking about the pathway of med school, residency, fellowship, how did you deal with each stage financially? Manaya. Sorry if I said it wrong.
Yeah. Med school. So the 6-year program. So first of all, my parents, we didn't have college funds. Like I took out loans. I accrued a lot of student loan debt. being part of that 6-year program. So that's how I survived med school. And then I also worked part-time to support myself financially, which helped offload some of the pressure, well, I guess it was more pressure for me, but it helped me financially survive med school. Residency, I lived within my means of you get paid as a resident. So, and how much we were paid in Kansas City was adequate for the standard of living in Kansas City. And then fellowship, you're paid a little bit more. So you can live off of that. And then I also took a second job in fellowship. We call it moonlighting, where you work in a hospital or a clinic providing care. So I supplemented my income that way. What else have I done? I think those are that's kind of how I did it. I didn't have kids in residency. I've got senior dogs though that I pay for all of their medical care. And I will recommend pet insurance. If you don't have pet insurance, it's totally worth it for pets. It saved me a lot of money for my dogs. So that helped a lot as well. I think it's a lot more challenging if you have children. If some people choose to have kids in med school or residency and fellowship, which is like totally fine, but then you have to think about the finances of it. And some people are able to access additional support, like through communities or through federal funded things. But you have to have a lot of help too, and that's the challenge.
Okay, thank you so much, Dr. Bhatt. I'm gonna start our wrap-up session. We have 5 more minutes. Audrey, can you get the slides up, please?
Yeah, give me 1 second.
Thank you.
And while we're waiting, if folks can do the feedback thing, that'll really be helpful. They are like university academia jobs. They make us get feedback for all the things. That's the only way we ever get promoted. So if you have a couple seconds, that'd be great, but no pressure.
Okay, so as we wrap up today's session, let's take a moment to reflect on our journey together. Think about what resonated with you the most. Was there a particular moment or example that truly captured your interest? Feel free to answer these questions in the chat or share as a reflection on the PHS website. By sharing your involvement in today's session on LinkedIn, you're not only showcasing your learning, but also connecting with like-minded professionals. Remember to tag pre-health shadowing using pre-health shadowing at pre-health shadowing to amplify your reach and start meaningful conversations. This simple act can significantly enhance your professional network. I would like to repeat that if you are interested in becoming a part of pre-health shadowing, you can do so remotely and contribute from anywhere in the world. To get started, just register on our website to gain valuable experience and make a positive impact in the pre-health field. If you have any questions, feel free to ask or visit our website for more information. Once again, if you can, please consider donating, even if it's like $1. Our entire operation relies on the generous donations and the invaluable time contributed by our dedicated volunteers. This is what allows us to continue offering these opportunities to learners from all backgrounds and walks of life. If you have the means, please consider making a donation. Don't forget to take our post-shadowing assessment available for Dr. Bhatt's session on the pre-health shadowing website. By completing this, you will receive a course certificate completely free of charge. The assessment itself is a simple 10-question multiple choice quiz based on the presentation. This is a fantastic opportunity to add to your professional credentials and showcase your commitment to learning. Did you miss part of the session today? No worries at all. We've got you covered. You can visit our YouTube channel at Pre-Health Shadowing to watch any of our previous sessions for free. Remember that our goal is to provide accessible learning opportunities for everyone. So feel free to explore the channel at your own pace. We'd love for you to join us in our sessions every week. It's a fantastic opportunity to learn and connect with like-minded individuals who share your passion for healthcare. You can do so by reading and signing up for our newsletter, following our socials, and regularly checking the PHS website for any upcoming sessions. As we wrap up, I want to emphasize how much we value your presence here in the pre-health shadowing community. You are what makes these sessions vibrant and meaningful. Thank you so much for joining us and supporting our mission. Okay, so that wraps it up. Thank you so much, Dr. Vat. I really appreciate you coming on.
Thanks for having
We
me.
all appreciate it, actually. We all learned so much.
Yeah, it was so lovely being here, and thanks for everyone's participation.
Okay, I'm gonna stop recording. Okay, bye everyone. Have a wonderful night.